Hey guys, just a little. Nice work on that quiz. Everybody got extra points for that last one. That kind of threw everybody off. I wanted to see if anybody studied it. Everybody got extra points for that. That was good. A lot of people did. And I looked at 10 minutes to midnight, and I think 2 people or 3 didn't have their paper turned in, and it was turned in by midnight. So good work on that. Everybody's got their papers, and I have a million papers to read. So I will get right on that when we're done with this class. I'll be in the lab today at 1 o'clock. So probably a little bit earlier than that. When we're done here, I'll head over to school if anybody needs anything. And there was one other thing that I was supposed to mention. You guys got your scholarship stuff in. Sorry. I didn't write it down. If I don't write it down, I don't remember. But Mary will pop in and let me know if there's something else. Does anybody have any questions before we start our last and final lecture of the semester?
I do. For the ATI proctored exam, will the exam?
I don't know who this is. Who's speaking?
It's Sarah.
Hi, Sarah.
Hey, I'm just wondering when we take the ATI practice or proctored exam, does it appear the morning of? Because so far I don't see it.
Yeah, we unlock it and then you go in and you sign in and it'll be there. We unlock it that morning.
Okay, thanks.
But the practice test, thank you for letting me know the ones that weren't up, they're all up. And same with the VNs, they have it set up so that the VNs that joined the class, theirs is in a whole separate unit. So some people had it and some people didn't have it. So that was kind of weird, but everybody's up and running. So you do those, do your remediations and take your ATI. So that's good. All right. Hope everybody had a nice holiday yesterday. Now we'll have this last class to talk to. I'm going to wait just a couple more minutes because there's only 28 people in the class. And I know there's more of you, except I'm missing a student. So I'm going to mute you and try to call her. In your business, because this is our last one. And it's one of my favorite ones because I know people that have HIV or that have died from the AIDS virus, and it's pretty brutal. I will say though, in the past probably 15 years, so much has been done. In the beginning of this, when this all came to the head in our society, there wasn't a lot that was being done. They were, just kind of throwing up their hands, and there were all different kinds of treatments and not as much research as people would have liked to see. It's taken several years, and there's vaccines and whatnot that are coming out, and different pills that maybe you only take 1 pill a day. I mean, in the beginning of the HIV virus, when things first came out, it was so scary and so unknown. And the poor patients that were suffering from this condition would take like 7 pills 3 times a day or 4 times a day. Even it was a QID regimen. I mean, the pill boxes weren't even big enough to hold all the pills. There were so many. And we talk about it a little bit in the care of these patients. You'll see that, many of them have to have the pill boxes set up each week just to keep them on the right, prescription. So it was just, a lot has come about it. In Santa Barbara, we actually have Pacific Pride, and one of our new grads was hired to Pacific Pride to be the nurse case manager, and she worked there probably, I think, 11 years until that position was no longer funded. So she went to community health, to public health, and as a public health nurse for the HIV patients. So there's, we do have help in our community for this population, but it's pretty disheartening that, more hasn't been done sooner. This is a review of the cycle that the virus goes through and how it can be transmitted. And here on the right, you'll see how it can be transmitted: sexual contact, sharing needles that are injectables, and then baby to mother to baby, during pregnancy, birth, or breastfeeding. So a few things, taught early on in school, like as early as junior high school, safe sex is taught over and over again, and it still doesn't even make you 100%, using condoms doesn't make you 100% safe. And then sharing needles, there were several different programs where it was such a big controversy because sharing needles, they would have the needle drop-offs where you could bring your used needles for people that are addicted and get clean needles. And it was like like the library, you go in, you bring your stuff, they give you, but then there were there was legislation that said we're encouraging IV drug abuse. This isn't something that we should do. And on the other hand, people would say, well, it's going to be done anyway. We'd like them to be safe if they're doing that, safer, I don't know, it goes back and forth, but the needle exchange programs are still very active in California. I can't speak to the rest of the country, I don't know, but California, there are needle exchange programs everywhere. Mother to baby, if a mother comes into the hospital and has a baby and they are HIV positive, the baby gets the antiviral meds right away at birth. And there's the component of the breastfeeding, which they don't recommend the breastfeeding because it is a body fluid, and it can, there can be blood in the milk that you don't see, it's microscopic, but they don't encourage breastfeeding for HIV positive mothers. There's also a lot of controversy on that too, and I know some people still do. How it's not transmitted in air and water, saliva, sweat, tears, closed mouth kissing, insects or pets, or sharing toilets, food, or drink. So for healthcare providers, we protect ourselves with universal precautions. Okay, we protect ourselves as you're taught early on, like in semester 1, the universal precautions. You want to make sure that you are washing your hands, using gloves when any body fluids are going to be, in contact with you or could possibly be. That's why, there are times when you can just run in and like maybe, oh, you don't want to do that. I don't even want to say that, where you would take an IV out, or even maybe work with change a little dressing on a bloody IV site. That's better. You're not going to take it out without gloves. But there are different little things tasks that you could do that could expose you, and you may not know that there is a portal of entry, a microscopic little crack in your skin, on your hands or something, your arms. So if you get splashed or come in contact with that, or a needle stick, you definitely need to follow all the hospital protocol for that. I mean, it is super important to make sure that you report it. And some people think, oh no, I'm not going to say anything, I don't want to get in trouble. That's a terrible misconception. Nobody's going to get in trouble. We want anybody that does get exposed to any blood products or any, a needle stick, anything like that, that you come forward so we can help make sure that you go through the process and that you aren't, putting yourself at a higher risk. And then 2, we had a needle stick this semester, And it was such an unfortunate one because you all know when you're starting an IV, right? Okay, everybody, single one of you I've spoken to personally, when you are advancing and pulling back at the same time and you don't hear a click, you're not done. You can certainly take it out, but that click didn't happen for this one student that went to the ED, went to start an IV, went, full bore, so excited. And the nurse was she's just such a good teacher. She's a great nurse in the ER. And she said, look at my veins. I just worked out this morning. Go ahead and start one on me. She started it. It was perfect. And in disposing of the cannula, she hadn't pulled back and secured that needle and it poked her. The mistake is an accident. So the nurse has to get her blood drawn. The student that poked herself had to get her blood drawn. They have to go through all this protocol and make sure that both are safe. It was super unfortunate because she started that IV perfectly. Oh, that hurts me. You guys all did so great on that. That was just such a fun skill. I'm so glad. And I'm doing 2 more today and then we're done. Semester 3s are IV certified for the rest of their time in nursing school. But yeah, those are like the universal precautions that we're so careful about. And it's easy to do. Poking yourself is easy to do. One thing that can happen is in the lab, we tend to reuse things. So you could get that muscle memory of like recapping it or putting it back so that somebody else can use it, that kind of thing. In the hospital, obviously, we're not going to reuse anything. So it's kind of hard sometimes to get that mentality out of your head. Like in the lab, I still see nurses that get the IV bag, open it and spike it this way, because if they spike it this way, it's going to spill everywhere because somebody else has used it before and took the golf tee out. And there's just different things that you learn in the lab that aren't, how it is in real life. That's not how it is in the clinical setting. So HIV is a fragile virus transmitted only through direct contact with body fluids. Again, blood, semen, vaginal secretions, and breast milk. Transmission is sex with an infected partner or exposure to infected blood or body fluids, pregnancy, delivery, and breastfeeding. Those are just, the main forms of transmission. The pathophysiology, it's a cycle. The cycle is complex and it has several steps. So you can go from 1 to 5. And this all talks about how the uninfected per cell surface receptor fuses with the cell membrane. It goes down to the viral core content, then the reverse transcriptase. This is, a little more than what you need to know, but you do need to understand how this starts. And then it's double-stranded and using the integrated DNA. So as a blueprint, the cell makes a new viral proteins and viral RNA. This is something that proliferates very quickly. Oh, you're not going to be able to. I'm going to try one thing. Share sound. I want to see if this works. They worked on this, so let's take a quick peek at this.
One of these people brushes with new Colgate Total Plaque Pro Release. It dissolves and lifts away plaque for 2 times less gum-harming plaque. As for the other guy...
Sarah, good luck.
Be dentist-ready with Colgate Total.
If you shop with the Walmart...
All right, this is not the right
everything
thing.
You need. It's right at your fingertips.
Let's dismiss.
So you can spend a little less, to get a little more, to make life a little better.
Sorry, you guys. Here we go. Oh, good. It's the good one. Can you hear it?
Or human immunodeficiency virus is a virus that targets cells in the immune system. Over time, the immune system begins to fail, which is called immunodeficiency, and this increases the risk of infections and tumors that a healthy immune system would usually be able to fend off. These complications are referred to as AIDS, or acquired immunodeficiency syndrome. Now, there are 2 distinct types of HIV, HIV-1 and HIV-2. HIV-1 is more commonly associated with AIDS in the US and worldwide. HIV-2 is more rare and typically restricted to areas in Western Africa and Southern Asia. HIV-2 is so uncommon that HIV almost always refers to HIV-1. Alright, HIV targets CD4 plus cells, meaning cells that have this specific molecule called CD4 on their membrane. Macrophages, T helper cells, and dendritic cells are all involved in the immune response and all have CD4 molecules. Therefore, they can be targeted by HIV. The CD4 molecule helps these cells attach to and communicate with other immune cells, which is particularly important when the cells are launching attacks against foreign pathogens. So this little molecule is pretty important for our immune system, but it's also extremely important for HIV. HIV targets and attaches to the CD4 molecule via a protein called GP120, found on its envelope. HIV then again uses GP120 to attach to another receptor, called a co-receptor. HIV needs to bind to both the CD4.
Hey everyone, it's Sarah with registerednursern.com. In this video, I'm going to be talking about HIV and AIDS. Hey everyone, it's Sarah with registerednursern.com, and in this video, I'm going to be talking about tumor grading and staging for cancer. And as always, hey everyone, it's Sarah with registerednursern.com.
I'm sorry, that was a mistake. Not exactly sure. I hope we don't have to watch.
If you click where it says YouTube, it'll make it big over HIV/AIDS.
I know, but you guys are turned over to another screen now.
HIV, or human immunodeficiency virus, is a virus
Can you
that
see
targets
this?
cells in the immune system.
Oh, we're looking at
Over time, the immune system begins to fail,
Right.
which is called immunodeficiency, and this increases the risk.
Hold on. This you can see though, correct?
Yeah, we're seeing the slideshow.
Okay, I'm sorry, but hold on, we're going back.
HIV, or human tumors, for HIV. HIV targets and attaches to the CD4
We already saw that.
and the co-receptor to get inside the cell. The most common co-receptors
Hold on.
actually have resistance or immunity to HIV, since HIV can attach to them and get into the cell. In fact, even heterozygous mutations, which lead to fewer co-receptors on the cells, can make it harder for the virus to spread and results in a slower disease progression. For those without this mutation, though, once HIV binds to CD4 and either CCR5 or CXCR4, it gains access into the cell. HIV is a single-stranded, positive-sense, enveloped RNA retrovirus, meaning that it injects its single strand of RNA into the T helper cell. The retro part of the retrovirus isn't referring to its style, but refers to it needing to use an enzyme called reverse transcriptase to transcribe a complementary double-stranded piece of proviral DNA. Proviral just means that it's ready to be integrated into the host's DNA, so it enters the T helper cell's nucleus and pops itself into the cell's DNA, ready to be transcribed into new viruses. Pretty sneaky, huh? Well, here's the actual sneaky part. When the immune cells become activated, they start transcribing and translating proteins needed for the immune response. Ironically, this means that whenever the immune cell is exposed to something that causes it to start up an immune response, like any infection, the immune cell ends up inadvertently transcribing and translating new HIV viruses, which bud off from the cell membrane to infect more cells. Very sneaky indeed. One thing to know is that HIV is notorious for making errors when it replicates, and that during infection it can mutate to create slightly different strains of viruses. These viruses are all still considered HIV, but they behave slightly differently from each other and target different cells in the host. In fact, that host cell preference is called viral tropism. So let's start with HIV entering the body through sexual intercourse, which is how it typically spreads from person to person. At this early point, during what we call acute infection, the R5 strain of HIV, which binds to the CCR5 co-receptor, will get into macrophages, dendritic cells, and T cells. Usually, dendritic cells hanging out in the epithelial or mucosal tissue where the virus enters the body, captures the virus and migrates to the lymph nodes, where a lot of immune cells live. And the R5 strain of HIV essentially has a field day, infecting T helper cells, macrophages, and more dendritic cells, which leads to a big spike in HIV replication and the amount of virus found in the patient's blood. Patients typically experience flu-like or mononucleosis-like symptoms during the acute infection. In response, the immune system mounts a counterattack, though, and starts to control the amount of virus replication, and the amount of virus in the blood declines to lower but still detectable levels by 12 weeks, at which point the patient enters into the chronic or clinically latent phase, which can last between 2 and 10 years. If we plot the amount of T cells alongside the amount of virus, we'll see that they loosely mirror each other, which makes total sense, right? Initially, you have a considerable decline in the acute phase until the immune system mounts its counterattack. After this point, even though there might not be any clinical signs or symptoms with the virus is steadily chipping away at the immune system, and the number of viruses in the blood slowly increases, while at the same time T cells slowly decrease, losing about 1 to 2 billion T cells every day. During this chronic phase, T cell counts usually remain above 500 cells per cubic millimeter, which is about the size of the head of a pin, and patients can still fight off other infections fairly well, although some infections like tuberculosis become more common and severe. Now, remember how HIV can create mutations? Well, during the chronic phase of HIV infection, it's worth pointing out that some patients develop an X4 strain of HIV, which targets the CXCR4 coreceptor, which is essentially only T cells. These X4 strains kind of lay low in the lymphoid tissues and steadily destroy CD4 T cells, since about 90% of T cells are found in the lymphoid tissue. Not all patients develop the X4 strain, though, so it's not completely clear what the presence of this strain implies about the disease course. When the body's T cells drop low enough, between about 200 and 500 cells per cubic millimeter, patients start experiencing symptoms like swollen lymph nodes, or lymphadenopathy, as well as relatively minor infections like oral hairy leukoplakia, a hairy-looking white patch on the side of the tongue caused by the same Epstein-Barr virus that causes mononucleosis, as well as oral candidiasis, a yeast infection in the mouth. As more T cells are lost and the levels fall below 200 cells per cubic millimeter, the immune system becomes severely compromised, and at this stage the condition has progressed from HIV disease to AIDS. At this point, people experience things like persistent fever, fatigue, weight loss, and diarrhea, and the HIV count in the blood might increase significantly.
That's pretty much sums it up what we need to know about right here, what he just said. So let's let him finish.
At this point, certain conditions start to develop that are said to be AIDS-defining, such as recurrent bacterial pneumonia, pneumocystis pneumonia, and fungal infections like candidiasis of the esophagus. Other conditions include certain tumors and malignancies like Kaposi sarcoma, which causes lesions on the skin and other soft tissue, and primary lymphoma of the brain. Many people with AIDS die from infections that a healthy immune system would typically be able to fend off, like pneumocystis, cytomegalovirus, or Mycobacterium avium complex. Now, male-to-male transmission is the most common mode of transmission in the US, and male-to-female is the most common mode in resource-limited settings. Although less common, female-to-male transmissions occur as well, since HIV is present in the vaginal and cervical fluids of infected women. In fact, over 75% of all cases of HIV are contracted from sexual intercourse. The next most common means of transmission include things like intravenous drug abuse and mother-to-child transmission, which can be via the placenta during delivery or via breast milk. Other, much less common modes of transmission include accidental needle sticks and use of blood products like blood transfusions. As far as diagnosis goes, there are a few types of HIV tests that can be done. Antibody tests, antibody/antigen tests, and RNA/DNA tests. Antibody tests look for antibodies that the body's made against HIV. Antigen tests look for the virus directly. So antibody-antigen tests detect both antibodies to the virus as well as the virus itself. RNA tests screen for viral RNA, so they also detect the virus directly. And DNA tests look for copies of the viral RNA, since remember it's a retrovirus, so it copies its genetic material into DNA. For screening purposes, the recommended test is the antibody-antigen test, which is better at identifying early infection. It's also recommended, if the first test is positive, to follow it with a confirmatory test that looks for antibody or nucleic acids. There's currently no cure for AIDS. Treatment, however, can help somebody with AIDS live longer, healthier lives and help reduce the risk of transmission. The primary method is to use antiretroviral therapy, or ART. ART isn't a single medicine, but a combination of medicines that's known as an HIV regimen. These help slow down HIV replication, which gives the immune system a chance to recover and help fight off other infections more effectively. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends.
Okay, we're not gonna do all that today, but he does that one mention of where HIV gets overgrown, overdone, and turns into the AIDS, full-blown AIDS, is where like there's a slippery slope there for our patients. And when we have patients with HIV, and you'll have several, we have several HIV positive patients in the hospital. There's many people that are in Santa Barbara County that are HIV positive, but the medications are so much better now. I mean, there used to be a gentleman that I knew that was on like 7 meds 4 times a day. And that's so unrealistic. I mean, that's just such a hard life to have for these patients. A lot of the patients that are HIV positive are homeless. So we have public health nurses that go out to different areas where people don't, live outside, and check their meds and check their calendars. We'll talk about the calendars and everything, but it's part of like a treatment plan, the HIV regimen, that every person that is banked in the public health dockets, it shows you where they are in the disease for the nurses that are working with them, where they are, how long they've had it, what the possible exposures were, who the possible people they could have exposed. And a lot of times too, it's hard to keep it, not so much contained. Obviously, we would if we could, but it's hard to keep it under control when perhaps you have an HIV positive patient that is homeless and suffers from, a severe mental illness, where they're not really processing all of that. They don't really care. That's just not, some of them will go off their meds or fall away, like go MIA, missing for days, months. And, they show up in the ER with a full blown, one of these different infections that he was talking about, and then come back to public health is called, their caseworkers called, and they try to get them back on a regimen. But when somebody suffers from mental illness, sometimes that isn't what their priority is, or they have an understanding for it, or if they do, it's only temporary. So that's a really iffy thing. But HIV doesn't have any color lines. It doesn't discriminate. You could have a white collar business person. He or she may have been infected by partying with a dirty syringe, when they were younger, or even now. There's a lot of different things that you would be surprised at. That we had an elderly woman in her late 70s who had a blood transfusion before blood was tested for that. And this was, 25 years ago, but I was working in an office where I did the back office, lab and the nursing aspect of things. And it was shocking. It was for me because it was so new, and it was like this little old lady, and she had a blood transfusion after she had a colonoscopy, and she started bleeding. So they did a polyp removal. She became very anemic, blood transfusion, and, lived with taking 1 million pills a day. And I mean, she did live pretty long after that, but now anymore, you can take the antiviral meds, and oftentimes the virus shows as undetected in the bloodstream. So I'm not saying that it's a cure and it's eradicated the virus from the patient, but if the virus is undetected in the bloodstream, that is a big positive for these patients. Main symptoms of HIV, you'll see systemic would be fever, weight loss, the pharyngitis, sores or thrush in the mouth. Oftentimes dentists are the ones, when you're going in to get your teeth clean, when they check your tongue, that find the thrush and then have, the patient have further investigation. Sores in the esophagus, which means difficulty swallowing, difficulty eating things, coughing up blood, maybe that could be part of it. Muscle, just Malaysia, weakness, liver and spleen enlargement, so splenomegalia, malaise, headache, and neuropathy in the central nervous system, lymph nodes, lymphadenopathy, just the feeling where you can actually, a lot of times on examination, you'll be able to even see the lymph nodes kind of bulging without even palpating, skin rashes that don't kind of clear, and then nausea and vomiting. That's, that's an awful one to have. This is a good little picture that shows the weeks and years, and then the CD4 T lymphocyte count, how it goes up, and then the latency of how long it remains at a certain threshold, and then how it returns back up. I mean, if you see here with the viral infection, it says viremia, large viral levels in the blood for 2 to 3 weeks. Transmission is more likely when the viral load is high, and then chronic, it's prolonged. So it kind of stays at a low period for years, a low viral load. And then end stage is where it's, shot back up, life-threatening opportunistic infections appear, and people that end stage patients don't necessarily go to hospice right away. I mean, there are, there's the Serenity House does take these patients, but end stage, sometimes people still want to try to fight. They still, they've still got fight left in them. It says HIV stages of the HIV disease and the primary infection. So you'll see if the CD4 is greater than 500, community acquired organisms more likely to acquire bacterial pneumonia, more likely to have HSV or zoster's reactions, like a herpes reaction. From 2 to 500, there's a tuberculosis where you're coughing up blood, you're having the night sweats, you're getting the severe weight loss. And then less than 200, pneumocystic Girovici. I don't really know how to say that, but that one is they call it ROVI or something like that for short. Hypoxia induced by activity, interstitial infiltrates, and an increased LDH. So cryptosporidium, profuse watery diarrhea, sometimes gets mistaken for C. diff. Candida is like the oral thrush in the mouth, or the lesions, big sores in the mouth, and then the white thrushy, it's fungal pneumonia, cavitary lesions, or diffuse infiltrates on the x-ray. They're really pretty pronounced. And then it gets worse, less than 100, the toxoplasmosis, candidal HSV, CMV, esophagitis. The esophagitis, I can honestly say in patients that we've seen, is they really suffer. I mean, it even hurts to take a sip of water. They really suffer. When they cough up blood and the esophagus is so inflamed. That's a pretty bad one. Then the enteritis encephalitis makes people, dizzy, fatigued, fog brain. They don't know, and then again, less than 50, cytomegalovirus, cryptococcus, Mycobacterium avium complex, and then primary CNS lymphoma, so EBV associated. Now, if you look less than 50, you'll see like visual changes, headache, altered mentation, night sweats, weight loss, diarrhea, malaise, all of these things. Focal neural deficit, seizures is the scary one, and weight loss. Public health nurses do home visits, and especially when in that condition. This one, new CDC recommendations. This one is a little bit old. Yeah, that's an oldie, but I do know that when we do an assessment and these tests are done, these are all lab tests that are done. We do them at PDL for Cottage, but I think 4 of these 5 tests get sent out. Just recommendations for testing in the lab are, they will test the specimen and then they will further test it. And you can see kind of on this grid. And I know that the newer grids are much more advanced from the CDC. Cottage lab, Cottage diagnostic lab test, they'll do the immune panel. They do this and this, the HIV half antibody and the P24. I wouldn't say that I've seen a lot of this done, but a lot of times when they go to the ED and anything is suspected, they will run a full panel. Treatment, again, is changing every day. The patient that I took care of just last year went from taking a huge regimen of pills. I mean, hair loss, whole disconfiguration like of his face and everything. He was a very handsome man and went down to 1 pill a day, and his viral load, the virus was undetected. So this kept him where he needed to be for many years. And this last pill, I think he was on for the last 7 years. Interesting enough, some of the patients that take the whole cocktail don't want to change because they have kept their viral load down and they're used to the medication. And a lot of the HIV medications cause such severe stomach upset. Nobody wants a stomach upset. That's like one of the most horrible things to have to go through. So if they're on a highly active antiretroviral therapy or HAART, and it's working for them and the symptoms are not, they're bearable, they will stay on it. A lot of patients do stay on it. And in talking to these patients and the plans of care for them, the public health nurses go out, check their calendars, check their appointments for physician appointments, their lab appointments, and when and where they get their medications. Some of them have to get sent away and have to get sent to a PO box if they don't have a home, or sent to a person, a point person, a family member. A lot of medications got sent from different online pharmacies to Pacific Pride. And I do know that they have a medication bank there to where they'll help people. They come in and they get their meds set up for them. If they're not, they may not be homeless. They may just need help getting their meds ready, getting their meds put together. So this, I would say, is 1, 2, 3, 4, 5, 6, 7, wow, 8, 9, 10 medications. That's a lot of medicine to take for one person. Here's just some combinations. Like this is 5 meds or 1 med, a couple of meds. These are just different little combinations that we put up, just kind of make you see there are different ways of keeping your HIV viral load down. And here is the zidovudine or the ZDV. And it just tells you, how often it can be given PO or IV, what the absorption rate. It says management of the patient with HIV infection, prevention of maternal fetal HIV transmission. So there's different reasons why, like the ATV, and here treatment therapy mode, and it'll tell you what the side effects are, what the contraindications are. But I just like for you to see the names of them, because usually if they're a weird name like this with a VIR on it, they are for the HIV. HIV medication prep or pre-exposure prophylactic is something that if somebody thinks they put themselves in a compromised position or they were exposed, maybe like here it says pre-exposure prophylaxis, before HIV exposure, PrEP is taken every day before possible exposure, then is for people who don't have HIV and have a sex partner with HIV, have sex with people whose HIV status is unknown, or share injectables. Okay, then it says, how is it effective? Consistent with use of PrEP can reduce the risk of getting HIV from sex by about 99%, and from injection drug use by at least 74%. So I don't know, it's kind of weird to think that you're going to take these meds with the idea that you are going to be putting yourself in this kind of a position, but people have, different ideas. It says, ask your healthcare provider about prescription for the PrEP, or use preplocator.org to find out how you can get it. How do you get it? Well, you have to be, of course, it has to be prescribed to you, but here it says PEP, HIV medication, post-exposure prophylactic. So 2 to 3 pills daily, and you get put on a regimen. And here it says emergency situation PEP is taken within 72 hours after a possible exposure. And then it's for people who don't have HIV but may have been exposed during sex, at work through a needle stick or injury by sharing injectables or during a sexual assault. PEP can prevent HIV infection when taken correctly, but it is not always effective. So that's kind of like, it's just, I mean, I think it's good to know that this stuff is out there in case there is an exposure, but who knows down the road, like, let's say you take this medication pre and post and you do your PrEP and your PEP, and 5 years down the road, you do show up with an HIV infection. Could it have happened after that? Or, it's just, it's so sad and it's so scary and it's out there. And we do have, we did have at one point several students at our college that were getting worked up for their HIV status. And it was like, there's such a stigma. There was such a stigma. I think it's not as bad anymore, but they were getting the help that they needed through our health center at the college. There was, I think, in all, I mean, I know there's so many students at the college, but I think there was 14 students that were actually getting, their treatment therapy and everything through our health center at the college, because they didn't have insurance. And it was also coupled with the public health. Public health came and had, and they were all kept very confidential, and they were all, not any one of them knew. All we got were the statistical points, like the numbers and how many and that kind of thing. But, however you're going to get help is the best way to do it, because it says adherence to the antiviral therapy. That is the biggest thing. If you adhere to the therapy that's prescribed and you finally get the correct cocktail or the correct prescription, it can, number one, educate you. It can help you with, going further, and it can also help you from also spreading the virus, because there's a lot of education involved in this. It says adherence is establishing a readiness to start. We do a case study this morning and it'll show you, some people just aren't willing to start, or there's so much stigma behind it that, it's like torn the families apart, or had, somebody just, kicked out of the family, discommunicated. Nobody wants to talk to that person. And I don't see much of that anymore, but it is still, there's still stigma behind it. Probably about 12 years back, when another person was teaching this section, one of the students came to me from the class and said, I'd like to disclose this because I don't believe that the information that's being taught is correct. And I've had HIV for 26 years. And I said, okay, do you think I could share my story with the class? And I said, I feel like you're much more than just that. And I don't know that your personal information should be put out there with your classmates, or how all of them would feel about it. And this is a while back. And I don't even know now how somebody would feel about that, knowing that a classmate is, like divulging their personal information about their HIV status, because it's personal and people may feel differently about you or not want to work with you as close. I don't know if that's like not disclosing the information too could be kind of misleading. So I don't know how people feel about that. That's just, I told him I really didn't think, I said, you can always give that information and talk about it just in general and not you, or you could say somebody that you do know, but I didn't feel like him giving his information out like that was the smartest thing to do or the best thing to do. And he's perfectly healthy and, living a full life, and his HIV status with the medication that he takes now, he does keep in touch with me, is still undetected, and he's retired and just doing great. So it's just kind of, one of those stigmas that are attached to this. Adherence is provide education, and medication dosing is a big one. That's a big part of that nurse or caseworker's job. Review the side effects, anticipate and treat side effects, utilize educational aids, including pictures, pill boxes, and calendars. The pill boxes and calendars are super important. A public health nurse shared with us in the class that one of her patients who was homeless, his backpack opened it up, his meds were in the big, the big pill boxes that have 4 times a day, and the calendar is attached to the back, and he knew when his lab was, when his doctor's appointments were, and what day to pick up his medications. So those are the kind of things that are sometimes not easy for everybody to adhere to, but with help, I think that that really does help. Engage family and friends. If families are involved in your care, simplify regimens, dosing, and food requirements, because a lot of times it's difficult for these patients to take their meds and have a meal. It has to be planned out a certain way, because you don't want to take the meds on an empty stomach, but you don't want to take it on too full of a stomach, because you don't want to vomit the meds and not be able to take back what meds you need to eat. Nobody wants to fish through vomit to get pills, but these pills are all counted and very precise. So, which is why this conversation is kind of gross, but they have to know what works for them as far as eating a little something, taking their meds, waiting till the meds have been, like kind of processed through their systems, and then maybe having their meal after X amount of time. And you'd be surprised at how well people adapt to the regimens of dosing, food requirements throughout their day. Utilize the team approach, nurses, physicians, counselors, etc. There are services at, like, again, Pacific Pride is just like the SNA and Men in Nursing has donated to them when we used to make a lot more funds than we do now. When we were on campus, we donate every semester to them, and it's not a lot, but it's something to go into their bank so that they can help with these kind of things. They help people with their medications, like they can bank them there, get their meds ready, but they also help with like food, like maybe better quality food and clothing, that kind of stuff. So it's kind of an important service out there. A lot of the funds have been cut from it, but hopefully they're coming back. I don't know. That would be more peer counseling there and all that kind of stuff, those kind of services. Provide an accessible, trusting, non-judgmental healthcare team. And they did such a good job there. And public health also does a really good job too. Here are tips for HIV meds on time and all the time, are those pill boxes and calendars, and know, exactly when and where to pick them up. Diagnostic criteria for acquired immune deficiency syndrome or AIDS. And here you'll see the category C, AIDS indicator, the CD4 and T cell count is equal to or less than 200. And then there's the presence of an opportunist infection. If the OI is like the pneumocystis pneumonia, the cytomegalorhinitis, different things. I mean, really invasive and really hard for these patients to live with. They're already going back to the fatigue and the foggy brain and all that, the muscle wasting, all of that. And then you'll see here presence of an opportunistic cancer, like an invasive cervical cancer, wasting syndrome. And then the dementia, the ADC is the AIDS dementia complex, where, they're trying to get help, but they don't even know who they are half of the time. The dementia will set in, they don't know their family members or friends. And it's just like, it's super unfortunate. It's super sad to see. And you can see here on this table, it's in your book, the CD4T, it counts below 200. And then you can see the opportunistic infections, fungal, viral, protozoal, and then the opportunistic cancers where cervical, the Kaposi-sarcoma, Burkitt's lymphoma, immunoblastic lymphoma, and then primary lymphoma of the brain. There's the wasting syndrome, there's pictures, and they're just so sad because there was one boy, his story was he was a hemophiliac, he got a transfusion and acquired this. So clinical manifestations are, immunological low white cell count, and all the different things, infections, cancers, those things, integumentary, poor wound healing, the lesions that are like big purple sores and then they open, night sweats that are, so scary. Because in taking care of an elderly couple, she said, oh, Jack has to get up every night. He's just sweating and sweating. And I thought, oh, wow, that's random that all of a sudden. So I called the doctor right away and said, hey, this guy's having night sweats every night. And he seems a little peaked. And right away, the doctor said, can you ask him if in the past he's had any blood transfusions? So I asked him, he goes, oh yeah, back in, I forget what year it was. And I was like, okay, because we have to go to the doctor today and just get some lab work done. And I'm not going to alarm this couple in their late 70s, 80s, that I'm thinking he's HIV positive because of the night sweats, and he isn't exposed to anybody, and he lives, up on the hill in this big estate. And it was not HIV. It was not, he did not have HIV, but he did have an endocarditis from a dental appointment, an implant of a tooth or something. So that was all came out. But those are scary things when you hear that. That isn't just like somebody in menopause. Night sweats don't happen unless there is something severely going on wrong. Respiratory shortness of breath and cough, and GI is the diarrhea, nausea and vomiting. They lose a lot of weight. This one, the central nervous system, is a real hard pill to swallow because confusion, dementia, your visual changes, you're changing in your personality. Not only have you gone through all of this, okay, because it's a lot to go through. HIV is a lot to go through for anybody, for any family member, any friend, anybody. And then when it gets into the full-blown clinical manifestations of AIDS, changes in your personality, you hurt, you have visual changes, all of those things in the central nervous system seem worse than everything else put together. It shows you, opportunist infections and malignancies, and then the dementia. But I feel like the central nervous system and the AIDS dementia complex are really the hardest, not only for the patient, but for the family, because the patient doesn't know what's going on. It's not a good place to be, but at the same time, it is really a really difficult thing to have to go through. Let's take 10 and we'll come back. We do have one case study to do, and then we will be done. I'll see you guys back here in 10 minutes. The clinical manifestations, gastrointestinal AIDS prevention. It says AIDS prevention of transmission in the healthcare setting. So of course we maintain our standard precautions, but hand washing, protective barriers, gloves, masks, eye shields, and gowns. We don't ever recap needles. We know that. Clean spills of blood and body fluids immediately using germicide solution. Consider all body fluids to be contaminated. Avoid contaminated outside specimen containers during collection. And cleanse workspaces. For GI patients, you would do that with any patient, really. You just want to make sure that you're keeping things safe, clean, and like GI candidiasis, wasting syndrome. These patients are very compromised. I mean, this is an awful picture of the thrush mouth, but you will see patients with mouths like this. It's thrush, and maybe not to this degree, but here you can see the wasting. It says, picture of brother, the main story is when both were healthier, and he died of AIDS at age 11, he died of AIDS. So these patients are really just emaciated, and that was in AIDS Awareness Month is in May. Clinical manifestations for the oncological purposes would be the Kaposi sarcoma, the B-cell lymphoma, and it shows you just stages of HIV, primary, acute phase, chronic, asymptomatic disease, and then AIDS. And what I feel like we get exposed to mostly is the chronic asymptomatic disease, because the patients will come in with many different other problems, but you will see and you will be notified patient is HIV positive. That's just something that is, for healthcare providers, that should be common knowledge. Of course, it's all confidential and everything, but you'll see these different types of sores and lesions, and it's sad and it's scary, but it is out there. This is a very dry but very informative video that I watched last night late. It's 15 minutes, so we won't do it now because you guys can get onto your case study and then finish up, but it just says clinical manifestation. So it'll give you like the HIV encephalopathy, integument-wise, like herpes zoster. It goes through all of those pathophysiology symptoms, clinical depression. This one you guys are going to work with a lot in many different areas of nursing, but a lot of times a diagnosis can be a huge blow to anybody, and right away a person will shut down. They'll put themselves into like a depression, and it really can't be helped. Oftentimes it's something that you definitely want to get them help for. You want to talk them through it. Sometimes an antidepressant is in order, but for AIDS and HIV, there's so much stigma, guilt, shame, their self-esteem, feeling of helplessness, worthlessness, and a lot of them do have the suicidal ideations and go through with it. Loss of friends, maybe due to the disease, but also loss of friends and loved ones, not only to the disease, but because they have the disease. So people have cut them out. Easier to just let go of a patient, of a person with this condition than deal with it. So there are people that are like that, and they will do that to another person. Super harsh and sad. Challenges in school, in the community, financial challenges, because a lot of patients can't work or kind of get edged out. There's domestic violence, sexual and reproductive health challenges, and then the psychosocial support. A lot of people relate this to a stigma that is just something that they don't want to be involved with. Disclosure of your status is also, your own private conditions, I guess you want to say, are your business. But I do believe when it affects another person, and especially a spouse or a partner, they should be aware of your status. I mean, I just think that's only like, that's the right thing to do, in my opinion. People have reasons why they wouldn't, but like, for instance, disclosure of an HIV status to a family, they could come from a cultural background to where maybe their lifestyle would just completely have them eradicated from their own family, or, just that, they would feel the shame of maybe their behaviors or whatever it is. That kind of a disclosure just isn't going to happen. The treatment and health, you need support. You need the medical community's support when you have a condition like this, but you can definitely see in the center of this grid, there is the stigma behind it. The role of the nurse, what are some of the appropriate diagnoses? And here is just nursing interventions for HIV, just a little something that could help you kind of put it into perspective. There's prevention, of course, and then health promotion, detect HIV early, and then in acute, promote health and limit disabilities, manage the problems caused by the infection, and then maximize your quality of life and resolve the life and death issues. So here, this one, mental health, how is the patient coping? How are they adjusting? Are their finances okay? Are their families involved? Do they have any kind of spiritual issues? Because we can call our hospital spiritual chaplain, and they've dealt with so many different aspects of this condition, and they can help. And maybe somebody's not ready for that. There's just a lot of different things. I like these grids. I put them up there. I know they're dry and you're probably never going to look at them, but if you take a minute just to read them over, they really do put things into perspective as far as what our role is going to be. There is the certified nurse, ACRN certification. Every certification that I've ever heard of, that I've ever talked to anybody, and the one that I took, are so hard. They seem to be like 20 times more complicated than your board exam, for instance. They're so difficult, but this is somebody that is passionate about it. And that new grad that went straight to Pacific Pride, she did actually do her certification, and she has a certification for HIV and AIDS nursing. Just something to just put up there. It says at least 2 years of experience in the clinical practice. You have to have the education, management, research related to this area. Completion of filing the application, and then it does cost, I think it's like $300 or $400, just like all certifications are, but it is something that's out there. We have one case study to do. I've just started our breakout room, so let's see how they are. Okay, so in room 1, I'm going to just start moving people into room 1. Okay, let's look in room 1. And in room 2. All right, let's see if I can do this. Room 1. There's only 2 people in room 1 and everybody else is in room. 35 people in room 1, everybody else is in room 2. So let's go to the rooms and we'll go to room 2. Hold on. Move to room 2. Move to. It takes me a second. Sorry, guys. Okay, room 2 is full. Now we're going to room 3. All right, moving to room 4. There's 5 in each room.